Keisha.
And I'm Candace.
And I'm Stephanie. And for our EDS 522 class, we chose for disability the CHARGE syndrome.
The term CHARGE comes from the first letter of some of the most common features seen in children with CHARGE. C is for columboma. H is for heart defects. A is for atresia of Canoe. R is for retardation of growth and development. G is for genital and urinary abnormalities. And E stands for ear abnormalities and or hearing loss. There are several other features associated with the syndrome as well, such as a cleft lip and palate, tracheoesophageal fistula and atresia, facial palsy, swallowing problems, weak upper body strength, seizures, microencephaly, abnormalities of the pituitary gland, and poor immune system. The physical findings and symptoms of individuals with CHARGE syndrome may vary greatly. Columboma. This is a cleft or failure to close of the eyeball, which can result in abnormalities in the retina or optic nerve. Columboma can result in significant vision loss, especially in the upper half of the vision field. Surgery cannot correct columboma. However, glasses may improve visual acuity. Children with CHARGE are often sensitive to light and may need sunglasses outdoors as well as indoors. Heart defects. Approximately 80% of children with CHARGE are born with a heart defect, many of which are minor. However, some of the heart defects associated with CHARGE may be life-threatening. Tetralogy of Fallot is the most frequent type of heart defect. Atresia of Kearney. Children with CHARGE may have blocked or narrowed passages from the back of the nose to the throat. Surgery can correct this feature. However, many surgeries may be required. Retardation of growth and development. Most children with CHARGE are born average size. However, due to heart and nutrition problems or growth hormone deficiency, children may become smaller than average. Most children with CHARGE are developmentally delayed, which is often a result of vision and or hearing loss. Some children with CHARGE may have mental retardation with or without brain abnormalities. Genital and urinary abnormalities. Many boys have undescended testes and a small penis, and girls may have a small labia. Both may require hormone therapy to achieve puberty. They may also have kidney or urinary tract abnormalities. And lastly, ear abnormalities. Children with CHARGE may have short, wide ears with little or no earlobe, and they may be soft due to floppy cartilage. The outer portion of the ear may appear as though it has been snipped off. Hearing loss is found in approximately 80 to 85% of children with CHARGE, ranging from mild to profound.
Here are some facts about CHARGE syndrome. CHARGE syndrome refers to individuals with a specific set of birth defects and medical problems. CHARGE syndrome is a genetic condition. The first gene of CHARGE, CHD7, was discovered in 2004, and is usually sporadic with no other affected individuals in the family. There are rare families with multiple affected individuals, and CHARGE syndrome is not caused by any known exposure during pregnancy. It is not related to sex, race, nationality, religion, or socioeconomic status. There is a DNA test for the CHD7 chromosome that can confirm the diagnosis of CHARGE in many cases. Because not all people with CHARGE have a detectable DNA change, CHARGE is still primarily a clinical diagnosis based on physical features. The diagnosis should be made by a specialist who is familiar with CHARGE syndrome. The incidence of CHARGE is about 1 in every 8 to 10,000 children. The frequency is the same in males and females. There is a wide variation in the physical and mental abilities among individuals with CHARGE. Although there are many problems with CHARGE children, that CHARGE children can suffer and become healthy and happy citizens, appropriate therapies and educational intervention must take into account any hearing and visual loss which is present. The intelligence of children with charge is often underestimated due to the combined hearing and vision issues. Individuals with charge need supportive, loving homes, early intervention, appropriate and challenging educational vocational programs, and preventative medical care.
Lastly but not least, I will cover the frequently asked questions. What specialists should we see? This depends on the medical involvement of your child. All children whom charge is suspected should have examinations by heart, eye, hearing, and kidney doctors. Don't forget your pediatrician. Children with charge are children first. They need to be seen by a pediatrician for all of the regular things like immunizations, weight checks, and ear infections. Your pediatrician can be an advocate for you and your child in the complex medical systems. Will my child see or hear? In the earlier stages of a newborn's life, it is difficult to have accurate testing or be able to predict individual vision and hearing abilities. Many doctors will give parents a worst-case scenario. Early diagnosis, prognosis could be inaccurate. Routine visits to a pediatrician, ear, nose, and throat doctor, as well as an audiologist will help uncover your child's abilities. What additional services do you need? Most states have early intervention programs available for children from birth to age 3, and school-based programs from 3 to 5. Most early interventionist programs include services such as physical therapy, gross motor skills such as crawling and walking, occupational therapy, fine motor skills such as pinching and grasping, speech therapy, education, and possibly vision and hearing services. Many of the programs are paid for by the state and offer services at no charge for children who qualify. In some states, there are costs or fees. If you have not been put in touch with your local program, contact your local school district or mental health, mental retardation programs to find out what is available in your area. In the U.S., every state has a deaf-blind coordinator. Your child does not have to be deaf or blind to qualify. If he or she has vision loss or hearing loss, he or she may qualify for services through the deaf-blind program. If you have not heard of these programs yet, ask to speak with a hospital social worker and ask him or her to help you find out more about what is available in your area. You may want to look into programs while your child is still in the hospital to get services started as soon as possible. What does my child's future look like? Although these children have many problems, they can survive and become healthy, happy citizens. Doctor's visits and medical problems taper off and or change as your child grows. Keep in mind, every child is different. Accept not knowing and enjoy today while doing what is possible to prepare for the future. Never underestimate your child's abilities. Always put the disability second. Be involved, interact, and enjoy, because as hard as it may be at times, they grow up fast, overcome many obstacles, and will make you proud. Thank you.
All of this information can be found at Charge Syndrome Foundation, which is www.chargesyndrome.org.